Hello and welcome to today's edition of Pathcast. Today is Friday, September 11, 2020. We want to shortly pause for a moment to remember the innocent lives lost in New York, Pennsylvania, and Virginia almost 19 years back on this very day during the terrorist attack. I am Rifat Manan in Philadelphia, and I am remotely joined by my good friend and colleague Emilio Madrigal, who is in Boston right now. Today, we are very excited to kick off a lung pathology lecture series to be delivered by Dr. Thomas Colby and Dr. Kevin Leslie. They both need no introduction to the world of lung pathology. Both Dr. Colby and Dr. Leslie are professors emeriti at the Mayo Clinic, and they are renowned for their contributions to the field of lung pathology. We are very honored to have them with us. They will deliver a 5-part non-neoplastic lung pathology lecture series entitled Approach to Non-Neoplastic Lung Pathology. Today, Dr. Leslie will deliver the inaugural lecture of the series, and the title of the talk today is Interstitial Lung Disease, Basic Injury Patterns. As always, please feel free to post your questions and comments on both YouTube and Facebook chat windows, and they both will answer those questions towards the end of the session. And thank you again for both of you to join us today. And over to you, Dr. Leslie, now.
Thank you, Rafat. It's a pleasure for both Dr. Colby and I to be here to present this first part of a 5-part series we've assembled to help you, the pathologists in practice, manage the difficult patient with lung disease who undergoes biopsy. Now, the biopsy is the end of the process, meaning the patient's already been worked up clinically by imaging and by the laboratory techniques. In the end, sometimes a lung biopsy is the only possible way to a solution. And we're going to help you manage these cases as they come across your desk. I'm presenting from New York. My colleague Tom Colby is in Arizona, and we'll be doing this course in the following way. The first course, I will present the bulk of the material, and Dr. Colby will make commentary throughout the presentation. We have pause places for him to do that. This is a primer on the clinical, radiologic, and pathologic approach to the diagnosis of interstitial lung disease. Our intended audience really is everyone involved in the care of the pulmonary patient, from the pulmonologist through the radiologist and finally the pathologist. All of their trainees will benefit from this presentation, as it's really designed to provide all of the fundamental foundation information necessary to approach these patients. So the part 1, as Rafat said, is Introduction to Domains and Patterns in ILD. And we're going to focus on mechanisms of acute disease, because acute patterns are the initial phase of every lung injury. And they're very important for you to manage because they are associated with high anxiety on everyone's part, from the patient, the patient's family, through the clinicians, and finally to you. Part 2, Dr. Colby will lead with additional patterns of lung fibrosis and inflammations, and including inflammatory infiltrates in interstitial lung disease. And then I'll be back with diffuse lung diseases having granulomatous features. Dr. Colby again with ILD showing airway centering and bronchiolitis. And the final lecture, non-neoplastic lung disease potpourri, will include a number of entities that we may not have fully covered in the first 4 lectures. So my lecture is Introduction to Critical Domains and Basic Patterns of Lung Injury and Repair. You need to know these things because we're going to touch on them throughout all 5 lectures. And this will give you a nice background in understanding why the lung does what it does after injury and why it presents to you in the slide the way it does. So I'm going to start with a case presentation. I'm going to introduce you to what we call domains, which are the facets of the interstitial lung disease patient. Then we're going to talk about acute injury, and the prototype is diffuse alveolar damage in ARDS. Then we'll talk about subacute injury patterns, where the prototype is organizing pneumonia, we'll move on to chronic injury, where the prototype is pulmonary fibrosis of all types, but especially UIP as it presents in patients with idiopathic pulmonary fibrosis. And finally, we'll talk about common causes of acute lung injury and how to manage them in your laboratory. We will also discuss the typical evolution of an acute injury experimentally and in practice, how pulmonary fibrosis occurs, the morphologic patterns associated with lung injury, and finally, how different biopsy techniques influence your approach and diagnosis in a given patient. So it's a lot to cover. Let's begin with the patient. 46-year-old man presents with rapidly progressive shortness of breath over several days. Chest radiograph shows bilateral ground glass infiltrates, and they look like this. Now you're going to look at this image and say, well, as a pathologist, I would say, yes, it's involving both the left and the right lung, but the left lung is much more involved. This is very typical for diffuse injury patterns, not to be completely symmetrical. All evaluations for infection clinically are negative and laboratory are negative. The patient's condition progresses to the point where at about 10 days after presentation, a lung biopsy is performed in hopes of identifying a treatable cause. And this is the biopsy that arrives on your desk. This surgical lung biopsy has a triangular shape, which is very typical. We have pleura typically on two surfaces, and the lung biopsy at low magnification has a distinctly eosinophilic appearance. There's fresh blood in the biopsy in a patchy distribution. And even from this magnification, we can see that there is a variable density of the injury here in the lung. We
don't see it, Kevin.
You can't see it?
No.
Rafat, I've got it up on my screen.
Oh, the slide?
Yeah.
No, not yet. We don't see it too.
Well, I have it up. Is there a reason why, if we go back to the PowerPoint,
yeah,
and then to the Apereo image scope, nothing? We have the lung biopsy, which at scanning magnification, as I mentioned, is very eosinophilic, and it has variable density at low magnification. And I can't stress to you enough that when you get a lung biopsy, stay at your lowest magnification for at least 20 seconds. I know it's hard to resist going to higher magnification, but try to get a feel for the whole process in the biopsy. So if we move in, to high enough magnification to actually see the cells, we see that the alveolar spaces are open and the interstitium is quite thickened. We also see these brightly eosinophilic membranous structures lining the inside of these spaces. As we look around through the biopsy, we see that this is variable, with some places having more proliferation in the interstitium and some places having less. There are even places where the lung seems to have become entirely solid. And some might look at this and say, well, this looks like pulmonary fibrosis. But in fact, this is a loose areolar type fibroblastic proliferation. And throughout this, we see the presence of large epithelial cells mixed into the process. So if we go back to the low magnification image, we can say that we have places that look quite acute, and we have places that look solidified, and which appear to have fibroblastic proliferation as part of an early fibroblastic repair. Other features in the biopsy may be the presence of pleuritis, and it's always important in acute injury to look at the biopsy and examine it for the presence of pleural inflammation. So go to the pleura, look at the pleura, and see if there are acute or chronic inflammatory changes. Sometimes this can be very helpful because the pleura and the lung are two separate organs living together. Embryologically, they are derived from different sources. So when the pleura is involved with a process and the lung is involved, it implies that there may be a systemic issue, not just a purely localized lung issue. So I don't really see anything here that will help me on that. So let's go back to the PowerPoint presentation. After you read this biopsy, all right, can you see the PowerPoint?
Not yet.
New share? Diagnose this as acute injury with hyaline membranes, which for many of you, you know this is also known as diffuse alveolar damage, which is a pathologic pattern. It's not truly a diagnosis. If this were a tumor, you would diagnose it based on its morphology, but for patterns of inflammatory interstitial lung disease, the pattern is just the beginning of the exploration. So you need to know what the differential diagnosis for diffuse alveolar damage is. And we'll talk about that throughout the presentation. Suffice it to say that in follow-up, you do special stains on the biopsy, they're all negative. The family is asked about the patient's condition before developing lung disease, and they say the patient has had an inflammatory arthritis that was not diagnosed or treated for a number of years. As I said, all cultures from the biopsy and special stains are negative. A broad panel of serologic studies are done because you or the clinician has realized that DAD, diffuse alveolar damage, can be a presentation of autoimmune disease. And it turns out the patient does have a positive ANA and also a positive JO1 serology, consistent with an amyopathic presentation of polymyositis. So we have a case where we've had to use domains to come to a solution, to find a disease entity that fits. We looked at the clinical and lab presentation, rapidly progressive, shortness of breath with arthritis, diffuse infiltrates on imaging, radiologic findings, is the radiologic domain. The pathologic injury pattern is acute injury with hyaline membranes, which is equal to diffuse alveolar damage. And finally, the disease entity that fits the anti-synthetase syndrome producing diffuse alveolar damage. So there's our full analysis. And you might think this is more complex than your typical pathology case, which is why a lot of people feel that the interstitial lung diseases are really too challenging to take on as a pathologist. What we're going to show you in these presentations over 5 separate lectures is that you can manage these if you have some tools and you have some basic knowledge about diseases that affect the lung diffusely. Urgent therapy was implemented for this patient, including high-dose solumedrol and pulse-dose cyclophosphamide. The patient recovered. So this is a success story. It's not always the case with diffuse alveolar damage. In some cases, no etiology is discovered, and despite all therapies, the patients succumb. It's a pretty high mortality rate, more than 50% today for all comers with diffuse alveolar damage. Tom, do you want to make some comments about our clinical presentation and domains?
Yes, from the point of view of the general diagnostic pathologist who is able to make a diagnosis, a confident diagnosis, about 90 to 99% of the time. In diffuse alveolar damage, it's frustrating because most of the time we're making a diagnosis of a pattern and not of a disease. And that's frustrating. And sometimes cases aren't like this. Sometimes the clinical story does not help out. Sometimes the laboratory doesn't help out. And we're left with diffuse alveolar damage of unknown cause. And then we have to give a differential. And we'll get into that differential later. But for me, that was frustrating as a young pathologist diagnosing tumors, where it's fairly straightforward, to something where we don't have an answer. And we just have to give a pattern diagnosis.
Thanks, Tom. So we'd like to emphasize the importance of this dance between the clinician, the radiologist, and the pathologist, because, as Tom said, for interstitial lung diseases, these are medical diseases affecting the lung. These are inflammatory processes for the most part. The pathology alone is really just one piece of this puzzle, and it's very hard to make a determination of the patient's real problem just from the pathology. So which door you come into doesn't really matter, because you're going to have to look at the domains, the other domains, always when you're approaching these patients. Pathologists will send us cases and say, look, I've got a biopsy, it shows this. And we'll say, well, tell us about the patient. They'll say, the clinician hasn't called me back. I know nothing about the patient. What about the imaging? The radiology just says patient with infiltrates. So we've lost a huge amount of value right there, because in the clinical and the radiology, I would say probably 85% of cases are already solved without the biopsy. So by the time a biopsy comes, you can be pretty sure that the clinical and the radiology has been relatively opaque. So we'd like to emphasize that you have to know the question being asked when you get a lung biopsy, a transbronch biopsy, transthoracic needle biopsy, or a surgical biopsy. You have to know what the clinician is asking you. You can't make the assumption as you would with a tumor. Well, it's a mass, and I have to solve it by looking at the pathology. So, question number one, is this a disease with a defined diagnosis and a proscribed therapy, like infection or sarcoidosis? If not specific, does the pathology suggest a mechanism of injury? That is, do we think this looks more like an inhalational disease, that is from the outside in, or does it look like an intrinsic disease, like an immunologic disease or a drug reaction? And finally, if the pathology is not specific, is there anything here that would give us insight as to the future of this patient's response to any available treatment? And the key here is, what are the available treatments? So I wanted to put a list of the available treatments so you have them in your pocket when you're facing these cases, because sometimes when we provide a descriptive diagnosis, the clinician will say to you, you haven't really helped me very much because I need to know how to treat and what to treat with. These are the things available to the pulmonologist. And you'll notice that the last one here is the lung transplant, which is a pretty drastic solution. But there are a few other things: antibiotics, anti-inflammatory agents, including steroids, anti-fibrotic agents that may be FDA approved for certain diseases, whole lung lavage to establish an actual therapeutic mechanism in diseases like alveolar proteinosis, or bronchodilators in a patient who has unrelenting asthma, immunoglobulin therapies for patients with immunodeficiency syndromes. So there aren't a whole lot of things, but there are some, and you need to know what they are. So let's talk for a moment about basic lung reactions to injury. We know from experimental models and evidence from patients with disease that injury and repair in the lung is ancient, and it goes through a highly reproducible series of phases. We have a graph here that has day zero, assuming we know what the day zero was, and a maximal prominence of features on the left. We have day 3, day 7, and day 14 and beyond. This is a critical period, the 2 weeks post-acute injury. Things will happen in the lung in a proscribed, very characteristic fashion. From day 0 to about day 8, the patient will have edema, will have cellular reaction, will have infiltration. And after about 10 days, that acute injury process will resolve, will become stable and associated with scar in many cases, or progress with scarring. That is, the scarring process continues to be active, either because the initial injury was quite severe or the injury has recurred multiple times. For example, a patient who takes a drug, gets a reaction, and then takes the drug again and gets a reaction, and takes the drug a third time and gets a reaction. You may see 3 of these distinct 10-day periods overlapping in the biopsy. In clinical acute respiratory distress syndrome, we do have information in which we look at the early phase and we see edema. We look at the intermediate phase where we see the formation of hyaline membranes, and these decrease as inflammatory cells migrate into the lung, and finally fibroblasts are stimulated to assist with repair. And the end process will be resolution, stable fibrosis, or progressive fibrosis. In the early phase, these are the hyaline membranes of diffuse alveolar damage. This fits here about day 1 to 3. The later hyaline membranes become thicker and more congealed, denser, and they have cells within the membranes, but the alveolar spaces are still relatively open. Note the interstitium, though, is getting cellular with these myxoid appearing fibroblasts. And out at about 10 days, that fibroblast migration leads to a picture that looks like this, where all the alveolar spaces are filled with these immature fibroblasts, a process we call organizing pneumonia. If you see hyaline membranes in this, you would call it organizing diffuse alveolar damage. Not all organizing pneumonias arise from diffuse alveolar damage. Organizing pneumonia can occur from anything from infection to drug reaction to autoimmune disease. The differential for diffuse alveolar damage includes trauma, shock, infection, sepsis, toxins, drugs, immunologic diseases, and when everything has been excluded, the clinician will call the disease idiopathic and can use this term, acute interstitial pneumonia. This is not a pathologic term. This has to have all possible causes excluded first, and you can't do that as a pathologist. You don't have access to all the information. So, Tom, any comments about mechanisms of acute injury and repair?
Not really, other than the fact that when acute lung injury looks awfully solid at low power, sometimes those cases are capable of completely reversing. In other words, the patients walk out of the hospital even though it looks like there's no functional alveoli left. And for that reason, it's actually surgical lung biopsies are not often done in acute lung injury to assess prognosis because they can look terrible. They're done to make a diagnosis, not really for prognostic purposes.
Thank you. So let's talk about mechanisms of lung repair following injury. And this is data derived from experimental models and corroborated by human observations. I've made a schematic here just to keep it simple. The lung is a very complex organ from a microanatomical standpoint. The 3-dimensional relationship to the 2-dimensional image you see on the slide is quite difficult to navigate at first and takes quite a bit of experience. So I've drawn it as a cartoon in which we have 4 alveoli represented. These alveoli are lined by type 1 epithelial cells. These are these quite flat green cells with a black nucleus. You can't see them under the light microscope, but they are present. And then these cuboidal cells, which are type 2 epithelial cells in the lung, these are the producers of surfactant and are also important cells in reforming the epithelial structure when these type 1 cells are damaged. The type 1 cells are quite sensitive to injury. So the type 2 cells have to be on ready to do repair when injury occurs. Let's look at one of these alveoli. And we see that an injury has occurred in this patient, and the epithelial type 1 cells have become damaged. These will actually disappear, and in their place, the type 2 cells will proliferate to fill the gap and later flatten out and reconstitute the type 1 cell lining. This is an example of an acute injury in the phase where the epithelial cells are proliferating, the type 2 cells are proliferating, and you can see them lining these spaces as hobnail, quite atypical cells. These cells are important to recognize because they simulate adenocarcinoma. This is one of the places where pathologists can have great difficulty distinguishing reactive atypia from neoplasia. So, if the injury is not too severe and subsides with leaving the basement membranes of the alveolus intact, you can have full reconstitution. However, if the injury is severe enough to damage the epithelial basement membrane, we have an image here of now the epithelial basement membrane discontinuous as red patches, and this triggers a response from the interstitium. Fibroblastic repair is initiated, and we see fibroblasts growing and beginning to migrate through the damaged basement membrane to produce a myxoid polyp in the alveolar space. And this is what they look like. This is a myxoid polyp growing into an alveolar space, another one over here on the right. So this polyp of immature fibroblasts surrounded by matrix, when all of the alveoli are filled with this process, we call it an organizing pneumonia, and that's what this looks like. This happens to be an organizing diffuse alveolar damage, as we saw earlier, because you can see the actual hyaline membranes in the organizing pneumonia. If you do a pan-cytokeratin stain on this biopsy, you'll note that these are not all fibroblasts. There are quite a lot of epithelial cells mixed into this process. The lung is going to try to reconstitute its normal structure out of this morass of epithelial cells and fibroblasts. If you look under the electron microscope, the alveoli will try to reconstitute in experimental models, and you can watch this process happen. Okay. Now, if the injury is limited, the polyps can be resorbed and the lung can be reconstituted. In normal structure of the lung, if all of the structure remains, it's fine. But if the structure becomes damaged irreversibly, the lung will reconstitute as large cystic spaces surrounded by varying amounts of fibrosis. And we call that process honeycomb lung. Here's an example of an autopsy lung showing severe honeycombing involving the periphery with some bullous cystic change, as you can see here. The most common cause of honeycomb lung is what we call pathologically usual interstitial pneumonia, or UIP. And this, again, is the most common manifestation of idiopathic pulmonary fibrosis in patients. UIP is not a disease, but a pattern of coarse, patchy fibrosis that eventually produces honeycomb lung. UIP produces a diagnostic pattern on CT in many cases, obviating the need for biopsy. UIP pattern must be present if biopsies are performed for a diagnosis, for you to make a diagnosis clinically of idiopathic pulmonary fibrosis. That is, for the clinician to do that. So here is the pathology of usual interstitial pneumonia. These peculiar looking, irregular, rounded areas of fibrosis surrounding relatively normal lung. This is the temporal heterogeneity of UIP, which Tom will talk about in more detail in the next lecture. This structure is similar to the polyps we just looked at of repair and injury. These occur characteristically in usual interstitial pneumonia and other diseases. And you can see there a bulge of fibroblastic proliferation at the edge of fibrosis. And they're lined by type 2 cells on their surface, trying to undergo repair. Tom, any comments about UIP mechanisms of fibrosis?
None other than, again, it's the low power appearance of the tissue that gives you the best clue as to whether the architecture of the lung has been destroyed.
Great. So again, the importance of the 4 domains: the clinical and lab presentation, the radiologic findings, the pathologic injury pattern, and then assembling all that into the possibility of a disease entity that fits. These are critical steps. If you skip any of the first 3 steps, you are at great risk for committing an error in your diagnosis. So if you have a lung biopsy, you really need to find out something about the clinical presentation, the laboratory data, and the radiology. When we get these cases in consultation, I would say on average, surgical lung biopsy is going to require us to explore the clinical, read the history and physical, look at the radiology findings, maybe look at the CT scan on a disc, and then look at the biopsy. So we see this as essential and critical to the evaluation of interstitial lung disease, and I hope you will too. The clinical domain has 3 phases, and it's all about tempo of presentation. The acute, hours to days in evolution, the subacute, weeks to months in evolution, and the chronic, months to years in evolution. The radiologic domain has acute changes, which are most frequently manifested as ground glass and consolidation. These are the 2 terms used radiologically. They're actually part of a spectrum. Ground glass can merge imperceptibly into consolidation. Ground glass often precedes consolidation, which is a solidification of the lung tissue. In ground glass, it's hazy white clouds over lung structure that's still visible behind it. Consolidation obscures the background lung. The subacute presentation is also ground glass and varying amounts of consolidation, and there may be air trapping identified in this setting. The chronic phase is characterized by what radiologists call reticular patterns or reticulation, and also structural abnormalities with traction bronchiectasis and honeycomb cysts in some cases. Remember, the chest CT is a morphologic domain. We tend to think of this today as a radiology domain, but in truth, as morphologists, we're looking at the structure of the lung, and the radiology is a good facsimile of lung structure and pathology in the lung. For example, I'll show you a CT scan, which as pathologists, we are acutely tuned into observation. And we notice that this patient has something in the lung that doesn't belong. And that's kind of a bilobed looking dense nodule. And we also notice that the patient has something here in the chest wall. And this chest wall lesion is actually related. So as pathologists, we can actually see the whole picture if we look at the radiology. In fact, this is a package of cigarettes and a lighter that the patient took into the CT scanner. And this is the end effect of smoking. This is a lung cancer. So I really can't emphasize enough that the more you look at CT scans, the more you're going to appreciate that they are the gross evaluation of the lung today. If you look at gross autopsy lungs, you learn a lot. You look at CTs, you learn a lot. You can think of the radiology as having patterns, just as we do in pathology and as we do clinically. And here you can see ground glass and consolidation, fibrosis, nodules, and mosaic patterns. And each of these has a differential diagnosis associated with it. The pathology domain has acute morphology, which is edema, fibrin, and hyaline membranes. They look like this. Here we have fibrin in the alveolar spaces. Here we have inflammation in the interstitium. Here we have hyaline membrane formation. These are all part of the acute pattern. We have the subacute pattern, which is organizing pneumonia. We have chronic inflammation in the interstitium. This is what most of you think of when somebody says, I have a patient with ILD. These are cellular infiltrates, and Tom will talk more about their differential diagnosis in the next lecture. And then epithelial repair and early fibroplasia. Remember what I said about atypia. Here's an example of a case that was a needle biopsy of an infiltrate, got called highly suspicious for adenocarcinoma. A lung biopsy was performed of the lesion, and it was a nidus of aspiration pneumonia with aspirated food, and this was the reaction in the surrounding lung. This is benign. The chronic pattern is collagen deposition with remodeling of lung structure and honeycomb cysts on occasion. This is the prototype of lung fibrosis, usual interstitial pneumonia, a distinctive pattern of lung fibrosis. You can put these into a pattern, and I have one, as you'll see here on my left, these 6 patterns of interstitial lung disease, of lung pathology in general. We have acute, we have nodules, we have airspace filling, we have fibrosis, we have cellular infiltrates, and we have biopsies with minimal changes. All of the disease that can occur in the lung are here in the differential diagnosis, a very helpful guide to the patient who gets biopsied for interstitial and diffuse parenchymal disease. So patterns of acute injury with their differential. Diffuse alveolar damage has this differential from infection, from drug toxicity, from connective tissue disease manifesting in the lung, from clinical ARDS, from drug reaction, from acute injury of all types, acute eosinophilic pneumonia, from asthma, from drug reaction, from unknown etiologies, acute fibrinous and organizing pneumonia, also called AFOP, which is an idiopathic condition, but pathology will show acute fibrinous and fibrin and organization in the lung. You don't diagnose AFOP, you describe the features, and this can occur as a completely idiopathic condition. Vasculitis and immunologic diseases, things like GPA, systemic autoimmune diseases like our patient with polymyositis, anti-GBM disease, microscopic polyangiitis, Churg-Strauss syndrome, acute exacerbation of chronic disease, things like idiopathic pulmonary fibrosis that can undergo acute changes suddenly in the patient who has chronic manifestations first. So the litany for cases of acute injury for us goes like this. First, look for bugs. That is, look for infection if you have acute injury. Do at least an acid fast and a silver stain on any biopsy that shows fibrin and acute injury. AFB and GMS at least. If the patient's immunocompromised, you'll want to do more stains, maybe some immunostains for infection. Remember this, necrosis is a marker for infection in acute injury. So if there's an acute injury in the background and you find tissue necrosis, your differential includes infection, infection, and infection. So make sure you've done all the markers. And even if they're negative, you still have to say infection has to be the high in the differential diagnosis. Next, rule out drugs. Look at the clinical record. Ask the clinician about what drugs the patient is taking at home or in the hospital if the course is protracted. Then check the serologies, the CBC, and the SUD rate. This may tell you a lot about any systemic disease that's evolving in conjunction with the patient's acute injury. And when all of these evaluations are negative, the clinician can call the disease idiopathic, and then it would be acute interstitial pneumonia if diffuse alveolar damage is the acute pathology. Remember, histopathology rarely solves the issues alone. So back to our patient with acute injury, we look at and find hyaline membranes at high magnification. We find an organizing pneumonia pattern, which we would call areas of organizing DAD. This is probably 10 to 12 days from the initial insult, whereas the previous image is more like 5 or 6 days. So other places, we have the interstitium starting to become more cellular. We still have hyaline membranes. So all of these phases of injury are present in the same biopsy, suggesting that maybe the patient has had more than one acute insult over the interval of 10 days. Finally, I'd like to talk about how different biopsy techniques influence diagnosis. There are a number of ways of sampling the lung, and it's important for you to know how these affect your ability to make a diagnosis. Here on the left, we have a lot of the diseases that can occur in the lung, from malignant tumors to pulmonary hypertension. And we have three common biopsy techniques: the transbronchial biopsy, the transbronchial cryobiopsy, and the surgical wedge biopsy. And if we look at the transbronch, we see that a number of diseases can be diagnosed readily with the transbronchial biopsy. Some diseases are diagnosable on occasion if the transbronchial biopsy has been lucky enough to pick up on a patchy process in the lung. And finally, diseases that you really cannot diagnose with the transbronchial biopsy alone, you have to have corollary from the clinical and the radiology. If we look at the cryobiopsy, we see the cryobiopsy is more effective than the transbronchial biopsy because it has a bigger sample of lung tissue. But there are still diseases that are rarely diagnosed by cryobiopsy alone. And then finally, the surgical biopsy, which is often useful and effective, but not 100%. So, Tom, any commentaries? Sorry, I caught you getting a cup of coffee. Tom, any comments about?
Sorry, I had a cat that was locked in a closet.
We're talking about biopsy techniques and how they influence your diagnosis.
Yeah, the biopsy technique is partly going to be dependent upon what your clinician your clinician does. Cryobiopsy is done someplace, for example, and not done others. So that's going to affect what tissue that we see.
Yeah. Okay, I'd like to leave you with some key references for further reading. All of these are fully annotated and referenced. This is a free article, My Approach to Interstitial Lung Disease. You can download this. It has images, it has radiology, it has all the things we've talked about today. And transbronchial biopsy and the interpretation of diffuse lung disease, another important treatise on lung sampling and its limitations. So we have covered part 1 of the course, and next time, Tom will talk about additional patterns of lung fibrosis and inflammation, including infiltrates in interstitial lung disease. And we will stop here and give you, the audience, time for comments and questions. Remember to follow us on Twitter at LungPathGuys. And should you have a difficult lung biopsy, you can always go to lungpath.com. And we have a limited availability for lung consultation, but we will help if we can.
Thank you so much, Dr. Leslie, for this excellent discussion on patterns of lung injury. I'm looking online to see the questions from the viewers. Just give me a second. I think one of them is, commented that they have seen these 6 patterns of lung injury in all their walls of the residency room, and they have, they have been following this all the time, and want to know a little bit about the background of this diagram exactly.
This was a diagram that actually started in Dr. Colby's hands. He published a paper years and years ago on anatomic patterns of lung disease and their differential diagnosis. And what this poster attempts to do is to distill the many, many, many patterns of pathology into a few basic patterns that have a broad differential each. So the poster, if you go to 6patterns.org, the poster is downloadable in high resolution, and you can print it in your own print shop or take it to a local printer and have it made physical for you, or you can just have it on your mobile device. But it is a very useful visual aid when you have a lung biopsy in front of you on your desk.
Thank you. There are a couple of questions I can see online. One question is, how often you get clinical details and detailed radiology in benign lung biopsies?
Tom, you want to take that?
I didn't hear the first part of the question.
The question is, how often do you get clinical details and detailed radiology in benign lung biopsies?
Sometimes, actually, it's very good because pathologists, some pathologists are aware of this, and sometimes we get great information. Sometimes we don't, and we have to lift up the telephone or go into the medical record. Obviously, there's going to be cases where you don't get clinical history, and sometimes we deal with those by just saying, based on the limited history we have, the differential includes A, B, C, and D. If you want to discuss this case, please call. Then that puts the onus back on the clinician to provide some history. That's a problem, and it's always been a problem in pathology, getting enough clinical history. But these days, I'm surprised at how good pathologists are at providing some of that information.
And I think the electronic record has a lot to do with that. You know, it's difficult to track down your clinician, but believe me, they want to talk. As a pathologist, you may not feel comfortable having that back and forth with the clinician about your biopsy. So one of the things that we do in our service is that we try to bridge that gap to make sure that nothing is lost in translation. So we'll reach out to the clinician. We'll ask for the radiology. We'll either review it ourselves or have a colleague radiologist look at it. In a consultation practice, it's what you have to do. In your general practice, it's very important when you get that biopsy and no history, don't think that the clinician is disregarding you. It's just they don't have an easy mechanism to fill you in with all the detail at the time of biopsy.
Thank you. The next question is about COVID-infected lungs. So do you have any comment about lung pathology in COVID-infected lungs?
Well, we've seen a number of biopsies. These aren't done very often in COVID patients. As Tom said, you know, when you know the patient has a viral pneumonia, there aren't very many advantages to doing a biopsy. Only disadvantages for the procedure itself to cause pneumothorax or other complications like air leak. And so clinicians are loath and surgeons are loath to biopsy these patients. The biopsies we do get are ones where either the data on COVID is incomplete or the patient has another reason for the biopsy. For example, we had a recent case where the patient developed a hemothorax 2 weeks into their COVID infection, and the hemothorax continued to accumulate. So the surgeon actually went in to seal off the lung where it was bleeding and then said, you know, while I'm here, I'm taking a piece of lung tissue for evaluation. Not very helpful because it shows, in that case, an organizing diffuse alveolar damage. In my experience, there are no particularly classical features to COVID infection to tell you it's COVID infection. There are no viropathic cytopathology changes. The patients will often have microvascular thrombosis, but this will occur in nearly all cases of severe acute injury from any cause. Tom, any comments?
Yeah, no, I agree. I think that in the autopsy studies that have been done, there's a little more often hemorrhage, a little more often thrombi, and sometimes small infarcts in COVID cases of DAD compared to other DAD, but I'm not sure that you could hang your hat on that as a diagnostic finding.
Right. There's another question. This is about if we have different patterns, how do we report? Should we highlight the most predominant pattern, and how do we report it in transplants or explants?
That's an excellent question. So remember the mantra, okay? Acute injury is the one ring that rules them all. So my tendency is to always, in any biopsy, I focus first on the acute injury. And then I talk about other features in the biopsy, because the acute injury is going to dominate every aspect of that patient's care for the present time. So focus first on the acute and try to get an explanation for why the acute has happened. Then look for other things in the biopsy, like the presence of granulomas, the presence of fibrosis in the background, or honeycomb change. So there is an order to things. And in the poster, I tried to order it like this. Acute injury, pattern 1, leads to organization airspace filling, which is pattern 4. Pattern 4, if left untreated, will evolve to pattern 2 fibrosis. So acute injury, subacute injury with organization, fibrosis are the 1, 2, 3 patterns. So that's the way to kind of think about it and focus, in my view. Tom?
Yeah, just a comment about that. The question was, if there's multiple patterns, what do you describe? Remember, when you get a biopsy, your job is to answer the clinical question, and the clinician may want to know, what is the cause of this patient's acute worsening? The biopsy may show honeycombing, which is obvious at low power and easy to see, and the acute injury, which is actually causing the current problem, may be less obvious. So always remember, what is the question? And the question would be, why is this patient acutely worsening? And that's because there's acute injury occurring on a background of fibrosis and what we call acute exacerbation of a chronic interstitial pneumonia.
Right. Here's another question. How frequently do we see microthrombi in diffuse alveolar domains?
Want me to take that, Kevin?
Very common.
Yeah, it depends on how hard you look for them. If you look really hard, you'll find them very commonly. Right. Anecdotally, they're more frequent in COVID, but I'm not sure they're specific to COVID.
Before COVID, every diffuse alveolar damage biopsy would come with a note from the pathologist saying, I'm very worried that this is lung disease on the basis of thromboembolism because I'm seeing thromboemboli in vessels. In fact, even some bone marrow emboli in vessels. And these are very common in severe acute injury in the lung. Unfortunately, not very specific in my experience.
Here is another question. How good are CT-guided lung biopsies in making diagnosis of non-neoplastic lung diseases?
You can take this one, Tom.
Short answer, not good. In fact, there's very few places that would do that. CT-guided biopsy is generally to go to a mass lesion or a focal lesion. They used to do drill biopsies in interstitial lung disease, but the incidence of pneumothorax was so high and the diagnosis rate so low that I don't think that for practical purposes, CT-guided biopsies are done in non-neoplastic disease unless it's a localized process such as an abscess, aspiration, or something like that.
Right. Here's another question. How do you avoid the trap of interpreting regenerative atypia as cancer?
Not everybody does, and we've all made our mistakes.
Ask a friend. Yeah, always share those cases around. Now, I'll tell you something that I don't know. I can't prove it 100%, but my recommendation is to not diagnose cancer in the presence of background acute injury.
Agree.
I mean, you may be compelled to do it. You may have no choice because you can have a cancer and you can also have acute injury. But when they're mixed together, more likely than not, it's going to be a reactive atypia that's fooling you. So back off at least 1 degree on your cancer diagnosis when there is associated acute injury.
Right. There's another question here. How often do you see diffuse alveolar damage associated with tumor?
I would say not common. I can count probably on one hand the number of cases where I had a clear diffuse alveolar damage and maybe lymphangitic carcinoma. And maybe they were just coincidental processes. Maybe one triggered the other. I don't know. I mean, maybe the lung tumor, maybe a diffuse tumor has triggered an acute injury, but it's a very uncommon thing to find in the biopsy.
Yeah, I would say true and unrelated. Sometimes a patient may have a silent tumor and presents with an acute lung injury pattern, and it's the acute lung injury pattern that then leads to an X-ray that leads to the identification of a tumor, but that they're not really directly related.
Right. Let me see what question I have next. 1 second. So, what is your opinion about cryobiopsies in the ILD approach? Is for all ILD or would you select?
This is your baby, Tom.
I think that depends on the skill of the operator. At some of the places I've worked with, they will do a cryobiopsy on just about anybody who doesn't have pulmonary hypertension and some of their contraindications that they have. At most institutions, clinicians are a little more reticent about cryobiopsies and do them less often. But that's really a function of the institution you're at rather than any basic guidelines for cryobiopsy. If you're good at cryobiopsy, you can do it for basically all comers with interstitial lung disease,
including patients with transplant, lung transplant.
Right. Here's, I think, another question here. Can we objectively score the changes in the explants as we do, for example, in liver cirrhosis?
Let me see if I understand the question. In the lung biopsy or in the explant?
Explants. So can we objectively score the changes in the explants, similar to what people do in liver cirrhosis? I think I got the question right.
Yeah. So we're assuming the patient has disease severe enough to undergo lung transplant, and you receive the explanted lung in your laboratory, and you do 20 sections, and you want to grade the degree of fibrosis, as I understand what you're saying, as we would grade fibrosis in a liver biopsy with early cirrhosis. And I would say we don't really have an established mechanism for grading degree of fibrosis in the explant. So we don't have criteria for mild fibrosis or moderate fibrosis or severe fibrosis with cutoff points. Tom, would you agree with that?
Well, I would say we hope it's severe enough to justify the surgeon taking the lung out.
Yeah.
As far as I know, we don't have a grading scheme. And do we grade fibrosis in livers after they're explanted? Basically, we can, but there's no real need to do that because grading is something you use for prognosis and management, and the management already is done. They've taken the organ out, so it's not like they're going to put it back in if it's not bad enough.
Right.
Right. So I think we have come to the end of the QA session. And if viewers, you have more questions, so please feel free to send the questions to us either on Twitter, or you can send us emails, and you can directly reach Dr. Leslie and Dr. Colby on their Twitter handle. So they would be more than happy to answer your questions. And Dr. Leslie and Dr. Colby, you would be so happy to hear that we had viewers, at least several hundred viewers who attended the session live, and they came from so many different countries from all over the world. And I could keep track of at least viewers from 30 different countries who have defied time zone and listened to your talks. And there were viewers as far away from Uzbekistan, Yemen, Philippines, Iran, Iraq, Colombia, Greece, Kenya, Myanmar, Nigeria, Israel, Ukraine, Jamaica, and of course we also had a lot of viewers from US and many from India also joined in. And thanks again to our viewers for listening to the lectures, podcast lectures. And as always, if you like our lectures, please visit our website. So we're www.pathologycast.com, where you can have all the updates about upcoming lectures. And in fact, in the website, you have all the lectures arranged by subspecialty so that you can watch those lectures. And they are also arranged by the presenters. So if you can go to the presenters, then you can see the lectures delivered by those speakers. And also, please don't forget to subscribe to our YouTube channel, that is Pathcast, and follow and like the Facebook page by the same page. And of course, please don't forget to subscribe to our newsletter so that you can stay connected with all the upcoming lectures. And our next lung pathology lecture series talk will be on October 2nd. That will be on additional patterns of lung fibrosis and inflammatory infiltrates in interstitial lung disease. And our next podcast is coming up on Tuesday. So that is at 8 a.m. Eastern time. And we will have a GYN pathology lecture, which will be delivered by Dr. Jennifer Bennett from University of Chicago. And the topic of her lecture will be the zebras of uterine mesenchymal neoplasms. So hope to see you all then. And thank you again, Dr. Leslie and Dr. Colby, for this excellent talk, the inaugural lecture of the lung pathology lecture series. So we are really looking forward to a great opportunity for all of us to learn these complexities of non-neoplastic lung pathology. And we are happy to have all of our viewers to join for the next lectures, which we want to call this lecture series as Patcast Colby Leslie lecture series. And thank you again, all of you for joining us. And thank you, Dr. Leslie and Dr. Colby, for your time and effort. Thanks so much.
Thank you, Rafat.
Kevin, can you stay on for a minute?